Hi, and welcome to RadOnc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria. I am currently a PGY4 resident at the University of Pittsburgh, and today we will be continuing our discussion of endometrial cancer with an overview of the evidence. In the last talk, we focused on the presentation, workup, and staging of endometrial cancer. We talked about how it is a surgically staged disease, and especially for early stage endometrial cancer, whenever possible, we prefer that patients undergo upfront hysterectomy, and then we determine their need for adjuvant treatment and the extent of adjuvant treatment based on the pathologic features that we identify. So their stage and their histology, and in newer studies, we're starting to incorporate their molecular phenotype as well. For locally advanced endometrial cancer, it is theoretically surgically staged, but in the modern era, we are actually moving away from upfront surgery, just because if it is locally advanced, then they need a radical hysterectomy, which is a more morbid surgery. So the thought is that maybe if we precede this treatment with chemoradiation, and then patients can kind of be downstaged at the time of surgery and be able to undergo just a simple hysterectomy as opposed to the radical hysterectomy. So we'll talk about the different evidence that kind of guides our management of endometrial cancer in the context of some of these seminal clinical trials. So we know that endometrial cancer is surgically staged, and pretty much any time we're doing surgery for a cancer, we do have to think about assessing the regional lymph nodes. And especially in cancers that we're removing surgically, if we don't assess the lymph nodes at the time of surgery, then we kind of lose the opportunity to do sentinel lymph node biopsy. Because if we take out the primary tumor, then it's hard to come back and do sentinel lymph node biopsy. So there is data for sentinel lymph node biopsy for endometrial cancer, as we will discuss. But let's first talk about some of the older trials that get at kind of what is the risk of lymph node involvement, and then move on to the FIRES study, which is actually our evidence for sentinel lymph node biopsy. GOG-33 was an older prospective observational study that looked at patients with early stage endometrial cancer after hysterectomy and pelvic and para-aortic lymph node dissection, as well as peritoneal cytology, and identified factors that correlated with risk of nodal involvement. And it turned out that on multivariate analysis, the grade of the cancer, the depth of invasion, so the degree of myometrial invasion, as well as intraperitoneal disease were predictive of lymph node metastasis. And if you take a look at the table on the right-hand side, the risk of lymph node involvement in very broad strokes, so very approximate numbers, just so that it's easier to remember. If there was endometrial involvement only, then the risk of lymph node involvement was very low, less than 5%. If there was inner middle 1/3 myometrial invasion, then across all the grades, the risk was around 5 to 10%. So around 5% for the lower grades, 10% for the higher grades. And then for the patients that had outer 1/3 involvement, the risk of lymph node involvement drastically increased with grade. So 10% for grade 1, 20% grade 2, and 30% for grade 3. And again, these are very approximate numbers, but the deeper the invasion and the higher the grade, the more at risk these patients were for lymph node metastasis. And then there was a study that came out around 4 years later, published by Morrow et al., that kind of looked at the difference between pelvic nodal and para-aortic nodal involvement. And what they found is that if patients had negative pelvic nodes, then it was pretty uncommon to have para-aortic nodal involvement. However, if patients did have positive pelvic nodes, then 30 to 55% of patients would actually have positive para-aortic nodal involvement. So having positive pelvic nodes is a very strong predictor for having risk of positive para-aortic nodes. But if there were no positive pelvic nodes, then it was fairly rare, less than 2% risk of having the para-aortic nodes. So the biggest things that you should take away from GOG-33 is that the depth of invasion and grade correlate to the recurrence-free interval as well as the risk of nodal involvement. And additionally, LVSI, or that lymphovascular space invasion, correlates to the risk of recurrence-free survival from that more updated publication. So now we know that for early stage endometrial cancer patients, the depth of invasion and the grade of the disease, as well as presence of LVSI, correlate to recurrence-free survival. But the question is, should these early stage patients be getting pelvic nodal dissection? Is it necessary to put them through lymphadenectomy of the pelvic nodes in order to kind of address these nodes? And so there were two randomized trials that were done to kind of answer this question. One of them was the Aztec trial, and the other was an Italian trial by Bendetti et al. And both of these trials took patients with early stage endometrial cancer who had undergone total abdominal hysterectomy and BSO, and they were randomized to surgery plus or minus lymphadenectomy. The Italian trial excluded patients with grade 1 disease and less than 50% myometrial invasion, so those very low-risk patients. The Aztec trial, it's important to note, 40% of the patients had external beam radiation postoperatively. But the conclusion from both of these randomized trials is that lymphadenectomy really did not improve overall survival or disease-free survival. There was no significant difference between the arms. And so the conclusion from these Aztec and Italian trials that randomized patients with early stage endometrial cancer to surgery plus or minus lymphadenectomy is that lymphadenectomy may help with staging, but it doesn't necessarily improve outcomes. Now, it's important to realize that surgery is not the only way that we can address the lymph nodes, right? We can also kind of sterilize the pelvic field by doing postoperative radiation. And these trials didn't really answer that question. They just answered the question of the surgical intervention. And based on these studies, it seems that it can help with staging, but it does not improve the outcomes. In a few minutes, when we get into the radiation studies, we'll talk about how radiation comes into play. I think it's a tricky conundrum because we know that the lymphadenectomy doesn't affect the patient's outcomes, but it does affect our adjuvant treatment. But we're lucky in the modern era because not only do we have better imaging modalities to assess for nodal involvement, we are also able to do sentinel lymph node biopsy, which is a more sophisticated, less invasive technique, and it still gives us that data on whether or not these lymph nodes are positive. And if they are positive, then that makes the patients have stage 3C disease, and that totally changes our treatment paradigm. So in the modern era, I would say sentinel lymph node biopsy is done for early stage endometrial cancer, and the data for this is based on the FIRES study. So this was a trial, a prospective cohort study from 2012 to 2017 of 385 patients that had stage 1 endometrial cancer, and they included all histologies, including high-risk histologies. And these patients underwent robotic hysterectomy with indocyanine green injection and sentinel lymph node biopsy, followed by pelvic and para-aortic lymph node dissection. And so the primary endpoint was really to determine the sensitivity of the sentinel lymph node biopsy because they could correlate the data from the sentinel lymph node biopsy to the data from the complete lymph node dissection. And so what they found is that 12% of patients in the cohort had positive lymph nodes identified, and 97% of these patients had these lymph nodes identified on sentinel lymph node biopsy. So the sensitivity of the procedure was 97.2%, and the negative predictive value was 99.6%. And so the conclusion from the FIRE study really is that sentinel lymph node biopsy can safely replace pelvic and para-aortic lymph node dissection in early stage endometrial cancer. And so it kind of makes that Aztec and Italian study kind of a moot point because now we can do sentinel lymph node biopsy, which is much less invasive, much less morbid procedure for patients, and have a very high sensitivity of 97%, and that allows us to properly stage these patients. Okay, so hopefully that now gives us a little bit of perspective on patients with early stage endometrial cancer, or basically stage 1 disease that's confined to the uterus. We know that these patients are at low risk of nodal involvement, but the risk increases if they have high-grade disease, including an aggressive histology, or if they have greater depth of myometrial invasion. And so the appropriate surgical staging for these patients involves a total hysterectomy, as well as a sentinel lymph node biopsy based on the FIRE study, which showed 97% sensitivity with sentinel lymph node biopsy. And oftentimes on these pathology reports, you might see some peritoneal or omental sampling as well, and some peritoneal fluid cytology, just to rule out involvement, because again, that would upstage the patient as well. So keep in mind that all of these are important components of the surgical staging, and then based on what the pathology shows, we determine the need for adjuvant treatment. So let's get into that now and talk about the studies that guide our adjuvant treatment for early stage endometrial cancer. The two main trials to be aware of that looked at the benefit of adjuvant radiation are GOG-99 and PORTEC-1. These trials both came out kind of after that data from GOG-33 that we talked about that told us that patients that had a greater depth of invasion, especially outer 1/3 myometrial invasion, presence of grade 2 or grade 3 disease, so higher grade disease, as well as LVSI, were at higher risk of recurrence after undergoing surgery. So we know that these three factors are really important, that they determine the risk of nodal involvement as well as the risk of recurrence after surgery. And so the thought was that if any of these risk factors were present, then maybe these patients might benefit from some adjuvant therapy. If they don't have deep invasion, if they don't have LVSI, and if they have grade 1 disease, they're probably very low risk and they might not benefit from any further therapy. But if they meet these intermediate risk factors, then maybe we need to supplement with some kind of adjuvant radiation to help mitigate their risk of recurrence. And so that's sort of what GOG-99 and PORTEC-1 set out to do. So GOG-99 took 392 women that had any one of these intermediate risk factors after they had undergone surgery. And that surgery included hysterectomy, pelvic and para-aortic nodal sampling, as well as cytology. And they included patients with stage 1 and occult stage 2 disease. These patients were randomized to either no further therapy or whole pelvic radiation up to 50.4 gray in 28 fractions. So remember, we're including early stage endometrial cancer patients with some intermediate risk factors. And they further stratified those patients into high intermediate and low intermediate risk groups. So remember those three risk factors: grade 2 to 3 disease, LVSI, and outer 1/3 myometrial invasion. The high intermediate patients were those that were 70 or older with one risk factor, 50 or older with two risk factors, or all three risk factors. And the low intermediate risk patients were all other patients. So I think this is nice and confusing how they kind of stratified these patients into the high and low intermediate risk groups. But if you're going to remember anything, just remember what these three risk factors were. So grade 2 to 3 disease, LVSI, and outer 1/3 myometrial invasion. And then based on that, they combined them different ways to get the high and low intermediate groups. What they found once they were randomized to no further treatment versus adjuvant whole pelvic radiation is that the 2-year recurrence significantly improved with adjuvant radiation. So the local recurrence or the regional recurrence, so any recurrence, went from 12% to 3%, and that was statistically significant. When they looked at the subgroups based on how they were stratified, they found that this was largely driven by the high intermediate risk group. So for high intermediate risk patients, the recurrence went from 26% down to 6% with the pelvic radiation. For the low intermediate risk group, it was just 6% to 2%, and it wasn't as, it wasn't as significant of a difference, and that improvement was really driven by the high intermediate patients, not necessarily the low intermediate risk patients. The other thing that they found is that when the cancer did recur, the most common site of recurrence was the vaginal vault. So the vaginal vault is kind of the vaginal cuff, or like the top of the vagina, where they take out the uterus and the cervix and they kind of sew together the top of the vagina. That was the most common site of recurrence. It was not in the pelvis. So these are important things to realize, right? We're getting a recurrence benefit, and that benefit is driven by these high intermediate risk patients, so patients that tend to have more than one of these risk factors, and older age patients. And the other important thing that came out of this is that there was no significant difference in the overall survival between the groups. So the difference was 86% versus 92% in terms of overall survival between the surgery and the radiation groups, and that was not statistically significant. And as you can expect, there was worse toxicity with pelvic radiation. So worse gastrointestinal, genitourinary, as well as hematologic toxicity with the pelvic radiation. So GOG-99 told us something important, right? It told us that in intermediate risk endometrial cancer, we can kind of think of it as high intermediate versus low intermediate risk. And these high intermediate risk patients are the ones that are driving this benefit that we see in the local control. So pelvic radiation is improving their local control, but it's not improving their overall survival. And it's also causing significantly worse toxicity in all three criteria, GI, GU, as well as hematologic. And so let's kind of take that information and think about it and move on to talk about PORTEC-1 as well, and then we'll discuss them both together. So PORTEC-1 is actually very similar to GOG-99. It's kind of the European version of GOG. GOG is an American study group and PORTEC is a European study group. And PORTEC-1, very similarly to GOG-99, also had the same thought. What if there are certain intermediate risk factors that actually benefit from post-op radiation? And so in the PORTEC-1 trial, they took patients with early stage endometrial cancer, so less than 50% myometrial invasion and grade 2 to 3 disease, or grade 1 to 2 disease with greater than 50% myometrial invasion. The only patients they did not include were patients that had both greater than 50% myometrial invasion as well as grade 3 disease. And these patients underwent hysterectomy and BSO with cytology, but no lymph node dissection. So in GOG-99, they underwent lymph node dissection. They did not undergo lymph node dissection in PORTEC-1. They did have biopsy if there was a suspicious lymph node, but there was not a dedicated lymphadenectomy. So PORTEC-1, I think, is a little bit easier to remember the inclusion criteria because we do think about patients this way: less than 50% myometrial invasion in grade 2 to 3 disease, or grade 1 to 2 disease with greater than 50% myometrial invasion. These patients were similarly randomized to no adjuvant therapy versus postoperative pelvic radiation to 46 gray and 23 fractions. And they were again risk stratified based on intermediate risk factors. So in PORTEC-1, the risk factors were a little bit different. They did age greater than or equal to 60 years old, greater than 50% myometrial invasion, and grade 3 disease. And high intermediate risk patients were any patients that had 2 or more of these risk factors, and low intermediate risk patients were all others. And very similar to GOG-99, PORTEC-1 concluded that postoperative whole pelvic radiation significantly improves the local recurrence, but again, not the overall survival. And once again, that improvement in local recurrence is largely driven by the high intermediate risk group. So overall, the 15-year local regional recurrence was 16% in the surgery alone group versus 6% in the radiation group, which was statistically significant. Once again, no significant difference in overall survival. And the greatest benefit was seen in the high intermediate risk patients. So at 15 years, the local regional recurrence went from 22% down to 10% in those high intermediate risk patients. And once again, 75% of the recurrences were in the vaginal vault, and they were finding that there was significantly worse GI and GU toxicity with pelvic radiation. So GOG-99 and PORTEC-1 both came to the same conclusion, right? If we look at all the intermediate risk patients, it's really the high intermediate risk patients that are benefiting from that adjuvant pelvic radiation. And the benefit is local regional recurrence, but it is not overall survival. And when we do see a recurrence, the most common site is in the vaginal vault. And if the next thought is, if we're causing so much increased toxicity with that entire pelvic field radiation and the recurrence is just in the vaginal vault, can we kind of narrow down our radiation field, which we will get to. Before we jump into PORTEC-2, which is the trial looking at that next logical question, I just want to take a moment to kind of compare the two trials that we just talked about, GOG-99 and PORTEC-1. So remember, both of these trials were looking at intermediate risk patients defined based on these particular intermediate risk criteria. So all of them really looked at age, having higher grade disease, and having deep myometrial invasion. And GOG-99 additionally looked at LVSI as well. And they had different ways of defining high intermediate risk patients. But what they found is that after undergoing surgery, adjuvant whole pelvic radiation really just benefited those high intermediate risk patients, not as much the quote unquote low intermediate risk patients, I should say. Keep in mind that both of these patient groups had total hysterectomy and cytology, but they only had pelvic lymph node sampling in GOG-99. There was not a dedicated lymph node dissection for PORTEC-1. What they found, as we said, is that local regional recurrence was significantly improved in the high intermediate risk patients. It was not driven by the low intermediate group. It was really driven by the high intermediate risk groups. And so if we want to have like very, very approximate numbers, somewhere from overall, the local regional recurrence went from somewhere around 15% to somewhere around 5%. And if they just looked at the high intermediate group, it went from somewhere around 25% to somewhere around 10%. But there was no significant improvement in overall survival. It was just a local regional recurrence benefit. The other thing that these studies found is that majority of the recurrences occur at the vaginal vault. And so as we will talk about in PORTEC-2 in just a moment, what we've found is that for some patients with these high intermediate risk factors, we can avoid full pelvic radiation and spare them all that GI, GU, hematologic toxicity and just do vaginal brachytherapy. In the purple circle on this slide, I've kind of included who we treat with adjuvant whole pelvic radiation in the modern era. And it's really patients that have both deep myometrial invasion and grade 3 disease. So 2017 FIGO stage 1B and grade 3 disease, stage 2 disease, so they have cervical involvement, or they have LVSI. And these are kind of the modern indications for whole pelvic radiation. And a lot of institutions will additionally add vaginal brachytherapy boost at the end, just because the vaginal vault is the most common site of recurrence. So it's really the highest risk patients in the modern era that have early stage disease with these high risk factors that are getting whole pelvic radiation to this day. A lot of those other high intermediate risk patients can just get vaginal brachytherapy, and the evidence for that comes from PORTEC-2. The rationale for PORTEC-2 was just as we discussed, right? We have the GOG-99 and PORTEC-1 studies showing us that there's a local regional recurrence benefit when we add whole pelvic radiation, and this is driven by the high intermediate risk group patients. But even in these high intermediate risk patients, the vast majority of recurrences occur in the vaginal vault. So the question is, can we spare them all this toxicity from treating the whole pelvis and just treat the vaginal cuff or the vaginal vault where they are most likely for recurrence? So PORTEC-2 asked this question, And in the early 2000s, they randomized 427 patients with early stage disease. And they included patients with less than 50% myometrial invasion and grade 3 disease. So that's the 2017 FIGO stage 1A grade 3 disease, or greater than 50% myometrial invasion and grade 1 to 2 disease. So it's grade 3 and 1A, or grade 1 to 2 and 1B disease, or they had endocervical involvement. They excluded patients that had stage 1B grade 3, so greater than 50% invasion and grade 3 disease, or high-risk histologies including serous and clear cell carcinoma. So they're taking basically endometrial cancer patients, and they had either 2017 stage 1A grade 3 or 1B grade 1 to 2 disease. And these patients were randomized to receive adjuvant radiation within 8 weeks. They were randomized to either receive whole pelvic radiation to 46 gray and 23 fractions, as they'd gotten PORTEC-1, or a vaginal brachytherapy treatment to 21 gray and 3 fractions with high dose rate brachytherapy. They also allowed for low dose rate and medium dose rate brachytherapy. In the modern era, most institutions are just doing high dose rate. So just remember 21 gray and 3 fractions HDR brachytherapy to the proximal half of the vagina, so the top half of the vagina. When they randomized these patients to adjuvant pelvic radiation versus vaginal brachytherapy alone, there was no significant difference in the local recurrence, the disease-free survival, the distant metastases, or the overall survival. The only thing that was slightly higher with vaginal brachytherapy was the risk of pelvic recurrence, and this was statistically significant. So if we look at the table on the right-hand side, we see that the local recurrence was very similar, 2.5 versus 3.5%. The risk of distant metastasis was just around 10% in both groups. The overall survival was just under 70% in both groups. The pelvic recurrence, however, was significantly worse with the vaginal brachytherapy alone. It was 6.3% versus 1% with the pelvic radiation. So patients that received pelvic radiation were significantly less likely to have a pelvic recurrence, which makes sense, right? Because we're sterilizing the pelvis with that radiation. However, the absolute risk of pelvic recurrence with vaginal brachytherapy was still only 6%. And so, the clinical significance versus the statistical significance is important to think about here. And are we okay with accepting just an absolute risk of 6%, given that the risk of distant metastasis is higher, around 10%? And so the other thing to keep in mind is the improvement in toxicity. So the patients that had vaginal brachytherapy had significantly improved GI and GU toxicity. They were at higher risk of mucosal atrophy and vaginal shortening because of the vaginal brachytherapy treatment, but they were also spared a lot of toxicity. And so knowing that pelvic recurrence was numerically higher and, statistically it was significant, but it was still, the absolute risk was, pretty low at 6%, still less than the risk of distant metastasis. The conclusion from PORTEC-2 is that these high intermediate risk patients should be treated with vaginal brachytherapy alone. And if you think about it in terms of the FIGO 2017 staging, that's stage 1A grade 3 patients and 1B grade 1 to 2 patients. So less than 50% myometrial invasion and grade 3, or greater than 50% myometrial invasion and grade 1 to 2. If you think about who we are not including in the PORTEC-2 trial, it's the stage 1A grade 1 to 2, right? Those are the really low risk patients. And then we're also not including the stage 1B grade 3 patients who we already said we still treat with whole pelvic radiation. So it's really these high intermediate risk patients that we are de-escalating the treatment and just trying to do the high intermediate, and just trying to do the vaginal brachytherapy. So just remember stage 1A grade 3 and 1B grade 1 to 2 for vaginal brachytherapy alone. The data for not treating the patients that have stage 1A, grade 1 to 2 disease comes from a Swedish study that looked at low-risk patients by Sorby et al. So the Sorby study, they took patients that had endometrial cancer less than 50% myometrial invasion, grade 1 to 2. So again, that's 2017 FIGO stage 1A and grade 1 to 2 disease. And they randomized these patients to either surgery alone versus surgery plus vaginal brachytherapy. And they found no significant difference in the risk of vaginal recurrence with the addition of vaginal brachytherapy. So the risk was 3% without any further therapy versus 1% with the vaginal brachytherapy, and it was not statistically significant. And so it's from this Sorby study that looked at low-risk patients that we conclude that observation alone is appropriate for stage 1A, grade 1 to 2 disease. So that's less than 50% myometrial invasion and grade 1 to 2 disease. It's possible that the addition of vaginal brachytherapy might benefit certain patients with intermediate or high risk factors. So if they have an older age, 60 or more, as was included in PORTEC-2 or LVSI, and there's a difference between focal versus substantial LVSI, as we have talked about in our overview. Those are some important criteria to think about when we are considering adjuvant vaginal brachytherapy. But the Sorby study tells us that stage 1A, grade 1 to 2, there's no significant difference in vaginal recurrence with observation versus vaginal brachytherapy. So we've talked about quite a few trials now, GOG-99 and PORTEC-1, that originally investigated which intermediate risk patients might benefit from any kind of adjuvant radiation. And we learned that it was really the high intermediate risk patients that do benefit from adjuvant radiation. However, when they do recur, the risk is most likely to be a risk of vaginal recurrence. And so that led to PORTEC-2, which told us that for a subset of these high intermediate risk patients, vaginal brachytherapy alone is good enough for local control, and we can spare them the risk of the whole pelvic radiation. We can spare them all of that toxicity that comes from whole pelvic radiation. With PORTEC-2, we realized that these patients are still at a significantly higher risk of pelvic nodal recurrence, but the absolute risk is still fairly low in the single digits at around 6% in PORTEC-2. And then we also have the Swedish low-risk study that told us that we can just observe certain patients that have stage 1A disease and grade 1 to 2 disease, so low invasion and low grade. So I just wanted to kind of summarize the major takeaways from all these early stage endometrial cancer trials. And keep in mind that the staging that I'm referring to here is the 2017 FIGO staging. The 2023 staging has been published. It's just a little bit more complicated, and it also incorporates grade actually into the staging. So I've tried to indicate what those stages are in the 2023 system, but for the purposes of this discussion, I think it's easier to just remember 1A is less than 50% invasion, and 1B is greater than 50% myometrial invasion. So let's work our way kind of from the bottom up on this slide. When can we just observe patients? It's really stage 1A, grade 1 to 2 disease based on that Sorby study, that Swedish low-risk study, that they don't have any benefit to adding any vaginal brachytherapy. If they have certain risk factors, such as a higher age, 60 or greater, or if they have positive LVSI, then vaginal brachytherapy might be something to consider because those kind of can increase their risk a little bit. But typically 1A, grade 2, that's when we think about observation. In terms of treating with vaginal brachytherapy alone, this comes from PORTEC-2, which looked at high intermediate risk patients that had stage 1A, grade 3 disease, or 1B, grade 1 to 2 disease, and select stage 2 patients that have minimal cervical involvement, really, are the patients that we think about de-escalating to just vaginal brachytherapy alone. The key thing to remember here is 1A, grade 3, or 1B, grade 1 to 2. And then finally, the highest risk patients that benefit from whole pelvis radiation, and some institutions will add the vaginal brachytherapy boost just because that is the site where they're most likely to recur. The whole pelvic radiation is really what we think about for patients that have 1B, grade 3 disease. stage 2 disease, so overt cervical involvement, and substantial LVSI. And so I think this is a nice way to kind of classify these patients with early stage endometrial cancer based on their postoperative pathology and kind of risk stratify them and determine which adjuvant treatment they would benefit from. The ongoing trial, PORTEC-4A, will probably be the future of endometrial cancer management. And PORTEC-4A is really integrating the molecular risk profile along with the histologic and pathologic features that we've already discussed. So they are taking patients with early stage high intermediate risk endometrial cancer who normally would just get vaginal brachytherapy as per the PORTEC-2 trial. And they are determining whether they are favorable, intermediate, or unfavorable based on their molecular risk profile. So if you recall from our overview talk, we discussed the POL-E mutation being a very favorable phenotype. We discussed the TP53 or P53 copy number high being a very unfavorable phenotype. And we also discussed MMR deficiency as a risk factor. So they were kind of using all of these different molecular markers and classifying patients into favorable, intermediate, and unfavorable groups. And then they are taking these stage 1 high intermediate risk patients and randomizing them to standard of care, which is just vaginal brachytherapy, or risk stratified treatment based on their molecular integrated risk profile. So these favorable patients with the POL-E mutation would just be observed. The intermediate risk patients that are either MMR deficient or MMR proficient, but with the CTNNB1 mutation, and those patients would get vaginal brachytherapy. And then finally, the most unfavorable patients with that P53 copy number high would get external beam radiotherapy. So the PORTEC-4A is really looking at taking high intermediate risk patients, and if they are favorable, then de-escalating from vaginal brachytherapy to observation, and if they are unfavorable, then escalating to actually full pelvic radiation. So this is a very interesting route that I think we're more able to kind of personalize treatment based on these molecular data that we now are able to obtain, and it'll be interesting to see the results. So that was a ton of information about early stage endometrial cancer. Let's move on now and talk about the adjuvant treatment that we think about for locally advanced disease. So now we're thinking about higher stage disease that's involving either the adnexa or the parametria or positive lymph nodes. We have two important trials to know in this space, PORTEC-3 and GOG-258. So let's start with PORTEC-3. PORTEC-3 took patients with high-risk endometrial cancer, defined as the 1B grade 3, so greater than 50% myometrial invasion with grade 3 disease and or LVSI, stage 2 to 3 endometrioid disease, and also stage 1 to 3 disease with serous or clear cell histology. So that's how they define these high-risk patients. And these patients were randomized to either undergo postoperative radiation plus or minus concurrent and adjuvant chemotherapy. So all of them got radiation, and then they were randomized to receive either no chemotherapy or concurrent and adjuvant chemotherapy. So the radiation dose was 48.6 gray and 27 fractions. And if they did have chemotherapy, then the concurrent chemotherapy was cisplatin 50 milligrams milligrams per meter squared weeks 1 and 4, and then adjuvantly they received carboplatin and paclitaxel. What they found is that the group that received chemoradiation had a significantly improved 5-year failure-free survival as well as overall survival, which was statistically significant. So the 5-year results went from 76% up to 81%. However, this improvement was largely driven by patients with stage 3 disease as well as serous histology. So if they looked at just the subgroup of stage 1 to 2 patients, there was no improvement in overall survival with the addition of chemotherapy. It was just 82% versus 83%, not significant. In the stage 3 group, the overall survival went from 69% with radiation alone up to 79% with the addition of concurrent and adjuvant chemotherapy. So a 10% improvement in the overall survival, and the failure-free survival also improved from 58% up to 71%. The other group that kind of drove that improvement was the group with serous histology. So their overall survival went from 52% up to 71%, and the failure-free survival went from 48% to 60%. So PORTEC-3 really looked at high-risk patients, and they randomized them to radiation plus or minus concurrent and adjuvant chemotherapy. And it was the stage 3 patients and the serous histology patients that significantly had an improvement in the overall survival and the failure-free survival. The problem with adding concurrent chemotherapy, though, is that it does significantly increase the acute and late toxicity with the addition of chemotherapy, and that was mainly driven by gastrointestinal and hematologic toxicity. And importantly, the benefit of chemotherapy is really just in stage 3 patients and patients with serous histology. I don't have a slide on this additional study, GOG-249, but it was a study that compared in patients with stage 1 and 2 endometrial cancer. They were treated with either external beam radiation or vaginal cuff brachytherapy plus chemotherapy. And with the addition of the chemotherapy to vaginal cuff versus the external beam, there was still no significant difference in recurrence-free survival or overall survival. So GOG-249 and PORTEC-3, they just give us further evidence that for those earlier stage patients, stage 1 to 2, there really is no benefit to chemotherapy, but there is potentially a benefit in these stage 3 and high-risk histology, such as serous histology patients. GOG-258 is kind of similar to PORTEC-3 in that they were looking at these high-risk patients or also stage 3 and 4A patients. But instead of randomizing to radiation plus or minus chemo, they were looking at chemotherapy plus or minus concurrent radiation. So they took patients with stage 3 to 4A endometrial cancer or stage 1 to 2 patients with serous or clear cell histology and positive peritoneal washings who underwent TAH and BSO with no residual tumor over 2 centimeters, and they were randomized to either receive carbotaxol alone or radiation, 45 gray and 25 fractions, with concurrent cisplatin, followed by adjuvant carbotaxol, and they did allow for a vaginal brachytherapy boost. These results of GOG-258 showed no significant difference in recurrence-free survival between the two arms. It was 59 and 58% in the two arms, not statistically different. The chemoradiation arm had significantly less vaginal recurrences, 7% down to 2%, as well as pelvic recurrences, 20% down to 11%. However, the chemoradiation arm did have significantly higher distant metastases, so 21% up to 27%. And in 2023, there was an update of GOG-258 presented at the SGO conference, and it showed that there was no significant improvement in overall survival with the chemoradiotherapy group. And so the conclusion from GOG-258, I think, is a little bit tricky. You know, we see that there is improved vaginal and pelvic control with chemoradiation, but there is a higher risk of distant metastasis, and that higher risk is likely due to the delay of systemic therapy. And so, you know, some people might read this trial and conclude that there's no significant benefit to the addition of radiation. I think for the large part, the RADONC interpretation is a little bit more nuanced than that. And I think there is a trade-off between local regional control and distant control. So we know that with endometrial cancer, especially locally advanced disease, they are at highest risk of distant recurrence. So having systemic therapy for those patients is very, very important to decrease their risk of distant recurrence. However, radiation still importantly provides a local recurrence benefit. So major takeaways from PORTEC-3 and GOG-258, as we just discussed, remember these trials are predominantly looking at patients with locally advanced disease, so stage 3 and stage 4A disease, and they're also looking at high-risk histologies such as serous and clear cell histology. And what we find is that the addition of chemotherapy in the postoperative setting improves overall survival, and most likely the main benefit that we're seeing is because of control of distant disease. These patients with locally advanced disease and high-risk histologies are at higher risk of distant spread, and chemotherapy is a systemic treatment that helps mitigate that risk. Pelvic radiation is still beneficial for local and pelvic control, but with PORTEC-3, we saw that concurrent chemoradiation was quite toxic. One alternate approach that has been utilized in the era of sentinel lymph node biopsy, especially in our institution, is to do adjuvant carbotaxol in the postoperative setting to kind of mitigate that risk of distant spread, followed by external beam radiation and brachytherapy boost for the benefit of that local regional control. Systemic therapy is also progressing in the modern era because of the advances in immunotherapy. And we actually do have a couple of trials for immunotherapy for advanced stage or recurrent endometrial cancer. So we have the RUBY trial as well as the NRG GY018 trial. Both of these looked at chemotherapy plus or minus, chemotherapy with placebo versus a PD-1 inhibitor. And remember, PD-1 inhibitor is an immune checkpoint inhibitor, inhibits the PD-1 receptor on T cells in our immune system and kind of downregulates those T cells. So the RUBY trial utilized dostarlimab, and the NRG GY018 trial utilized pembrolizumab. Both of these are PD-1 inhibitors, and patients were randomized to carbotaxol with placebo versus the PD-1 inhibitor. The RUBY trial found a significant improvement in 2-year overall survival and progression-free survival with dostarlimab. They did stratify based on MMR deficient versus MMR proficient, and they found that the results were significant in both groups, but largely driven by the MMR deficient cohort. And they found that there was an improvement in the overall survival as well, 71% versus 56%. Slightly higher grade 3 plus toxicity with dostarlimab, however. The NRG GY018 trial also did the same thing, but with pembrolizumab, and they found a significant improvement in 1-year progression-free survival with pembrolizumab of 74% versus 38% with placebo in the MMR deficient cohort. The MMR proficient cohort was also significantly improved, but to a lesser extent. So these PD-1 inhibitors, based on the RUBY trial and the NRG GY018 trial, prolong PFS in the advanced stage or recurrent endometrial cancers for both the MMR deficient and MMR proficient cohorts, but we see much greater improvement in the MMR deficient cohorts. So I think, again, in the era of immunotherapy, these are important discussions to have with our gynecologic oncology colleagues. I think there has, some folks have noticed a pattern of fewer referrals for stage 3 endometrial cancer patients, and these patients are omitting radiotherapy. But the reality is that omission of radiotherapy for stage 3 postoperative endometrial cancer has not really been tested in a randomized setting in the era of immunotherapy. And so I think combining these approaches is really important, and these are important to be aware of this data and to have honest discussion with our gynecologic oncology colleagues. We are almost done. I know this has been a lot of information. I just have a couple more slides on inoperable endometrial cancer and a quick summary, and then we will wrap up. So in terms of inoperability, remember there are 2 reasons that patients might not be good candidates. One of them is for surgical reasons. Either they have very extensive disease, or we often also think about patients, we think about offering upfront radiation, even if they just have extensive cervical or parametrial involvement, in order to spare them the radical hysterectomy and allow for simple hysterectomy. So there's kind of that surgically inoperable bucket, and then there's also medically inoperable, where patients are not a candidate for surgery because of their medical comorbidities and they just wouldn't tolerate a trip to the operating room. So let's start and talk about the surgically inoperable patients first. We have retrospective data from our institution at UPMC actually utilizing this approach of upfront external beam radiation and brachytherapy with or without chemotherapy to potentially allow for downstaging and allow for a simple hysterectomy, so a less extensive surgery, spare patients that radical hysterectomy. So the retrospective data from our institution took patients with, upfront locally advanced endometrial cancer, and they were treated with external beam radiation anywhere from 40 to 50.4 gray, plus or minus concurrent cisplatin, followed by a brachytherapy boost to a cumulative EQD2 of 60 to 70 gray. And 91% of patients had no clinical cervical involvement, and 58% had no pathologic cervical involvement at the time of surgery. All were able to have a margin negative resection with a PCR rate of 24%. And pretty good, local control results. 3-year local control, 96%. The regional control was 89%, distant control 84%, and 100% overall survival at 3 years. So this is just one institutional approach, but this possibility of upfront chemoradiation for patients that would need a very advanced surgery up front. In the second group of patients that we call quote unquote inoperable, remember the surgery is not kind of ruled out because of surgical reasons, more so because of medical reasons. So these patients are not safe to be taken to the operating room. And so for patients that have medically inoperable disease and very early stage disease, we can consider just definitive brachytherapy alone. So typically for patients with stage 1A disease and grade 1 to 2 disease and tumor size less than 4 centimeters. So think of these as patients that would have had surgery and no adjuvant treatment. We can treat with just brachytherapy alone. If they have more advanced disease, then we do definitive radiation, external beam radiation, plus brachytherapy. So if they have grade 3 disease or any more advanced disease. And I think we talked about the details a little bit more in the overview talk on endometrial cancer, but there's a really nice set of consensus guidelines from the American Brachytherapy Society that can help guide management of these medically inoperable patients. So for a quick summary of everything that we've talked about to this point, remember for endometrial cancer, we try for surgical staging whenever possible. And based on the FIRE study, this includes sentinel lymph node biopsy for nodal staging. For early stage disease patients that undergo upfront surgery, we treat with risk-adapted adjuvant radiotherapy. So the stages that I'm referring here, remember, are the 2017 FIGO stages, and 1A is less than 50% myometrial invasion, and 1B is greater than 50% myometrial invasion. So stage 1A, grade 1 to 2 patients can just be observed after surgery based on the SORBI low-risk Swedish study that we talked about. If patients have stage 1A grade 3 disease or 1B grade 1 to 2 disease, then they fall into that kind of high intermediate risk group from PORTEC-2, and they can be treated with vaginal brachytherapy alone. If they have more high risk features, so stage 1B grade 3, stage 2 disease, so cervical involvement, or substantial LVSI, then we typically treat with external beam radiation, and some institutions will add vaginal brachytherapy as well. And these were kind of the highest risk patients that were included in GOG-99 and PORTEC-1 trials. In terms of locally advanced disease, or more high risk subsets, so stage 3 to 4A disease, we know that these patients benefit from the addition of chemotherapy based on the PORTEC-3 and GOG-258 studies. So these patients are often treated with adjuvant carboplatin and paclitaxel, and some institutions will consider external beam radiation after that chemotherapy, plus or minus a brachytherapy boost to provide that local regional control benefit. In the modern era, though, since the publication of the Ruby trial as well as NRGGY018, I think the standard of care has really shifted, and we are now doing chemotherapy with immunotherapy with the PD-1 inhibitors. Dostarlimab as in Ruby trial or pembrolizumab as in the NRG trial. And then, further down the pipeline for both early stage and locally advanced are more molecular profile based therapies to kind of better personalize and appropriately escalate or de-escalate treatment. And then finally, we talked about inoperable endometrial cancer and chemoradiation followed by brachytherapy, followed by surgical consideration if they have very advanced disease. Or just brachytherapy versus external beam and brachytherapy for those patients that have medically inoperable disease. If you are still listening, thank you so much for your time and attention. As always, we are never able to go through all of the studies that have been done for a particular disease site, but hopefully this provided a good kind of outline of some of the most important seminal trials pertaining to endometrial cancer, and hopefully it helped to shed some light on some of the treatment paradigms and kind of why we do what we do when it comes to endometrial cancer. So I hope this was helpful to you, and thank you so much for your time.